Well, you guys could have been anywhere in the world, but you're here with me, and I appreciate that. Title of my lecture is On the Right Foot, Managing Diabetic Nerve Damage and Diabetic Foot Wounds. I'm going to do a whole lot of walking around. I don't like to stand stationary. This is a topic that is so very near and dear to my heart. I could have easily made this presentation 3 or 4 hours. So I've really condensed this down into about a 45-minute lecture and presentation on what I think is most pertinent for you guys to learn about with diabetes. So a little bit about myself. I'm a board certified podiatric foot and ankle specialist and surgeon, CEO, founder, and physician of Louisiana Foot and Ankle Specialist, and I'm currently the surgery chief and department chairman of surgery here at Memorial Hospital. So what are we going to talk about today? Hopefully we understand the etiology, risk factors, treatments, and complications associated with diabetes mellitus. Understanding the etiology, risk factors, treatments, and complications associated with diabetes. Understanding the causation and correlation of diabetic peripheral neuropathy and diabetic foot wounds or ulcers, and understanding the financial burden and healthcare costs associated with diabetes management, understanding the conservative and surgical management of diabetic neuropathy, and finally understanding the complex management of these foot wounds. So what is diabetes? Who here in this room has heard of diabetes by show of hands? Almost everybody, right? Who here can explain what diabetes is? Not a whole lot of people. So it's a deficiency of insulin needed for the uptake of glucose to synthesize glycogen. The liver is unable to store glucose, and in turn the glucose is released into the bloodstream, leading to hyperglycemia. Who here understood what that meant?
Excuse me, doctor. Yeah. Could you dim the lights a little bit for us old guys?
See if I can do that.
You don't have to turn them out, just kind of dim it so we can see the screen.
Yeah, it is hard to see.
What was your last question, Doctor?
Who here understood what I just said by that? I'm going to explain diabetes in a simple term. Diabetes is characterized or defined as insulin deficiency. There are 3 types of diabetes: type 1, type 2, and gestational. Gestational diabetes really isn't pertinent to this lecture, but it happens with females who are pregnant. 97% of the time this disease process goes away once they deliver or give birth to their child. Now, type 1 diabetics affects about 20% of the population. This is usually a diagnosis that is made within the 1st or 2nd decade of life. Insulin is a hormone that's produced in the pancreas that allows the glucose from the food we eat to be taken in by cells and be utilized as energy. The beta cells that produce insulin are actually attacked by the body in type 1 diabetics, so they are unable to produce insulin at all. So this is an early diagnosis that we find. Type 2 diabetes affects 80% of the population. That is what we're going to focus mainly on in this presentation. The body is able to produce insulin, but the body doesn't respond to it very well, known as insulin resistance. So that in a nutshell is diabetes. Incidence of diabetes. Louisiana ranks as the number 8th highest state in the U.S. at roughly 12.1% of the population. Boudin, Cracklin's. We got good food here. There's definitely a correlation between that. 30.3 million people in the U.S. suffer from diabetes. 1 in 4 don't know they have it. 84 million people in this country are pre-diabetic, meaning they have elevated blood glucose levels or elevated blood sugar, but not high enough to be considered diabetic. And diabetes is the 7th leading cause of death in the United States. So what are the symptoms of diabetes? Well, in medical school we learn polydipsia, polyuria, polyphagia, excessive thirst, excessive urination, and excessive hunger. So we can see here always being tired, frequent urination, sudden weight loss, wounds that won't heal, sexual dysfunction, always hungry, blurry vision, numb, tingling, hands or feet, always thirsty. Those are some very, very common symptoms that we see with our diabetic patients. So what are the risk factors for diabetes? Well, we're going to talk about factors that you can fix and factors that you can't fix. Who here in this room is older than 45 years old? Pretty much everybody, right? You can't change your age. Being 45 years or older certainly increases your risk for diabetes. Who here in this room knows a family member or relative with diabetes? That also increases your risk factor of developing diabetes. High-risk ethnic background, African American, Asian, Latino, American Indian, to name a few. Factors that we can improve: weight loss. For those that have not been diagnosed with diabetes, by losing 10 to 15 pounds, that can decrease your risk for developing diabetes by over 50%. Low activity level, cholesterol numbers, high blood pressure, those are all things that you can improve upon that can decrease your risk for developing this disease process. So diabetic peripheral neuropathy. Who's here have heard of neuropathy before? So DPN, or diabetic peripheral neuropathy, is one of the most common long-term complications associated with diabetes. There's a wide variety of signs and symptoms that demands a level of knowledge and understanding to facilitate proper treatment and intervention. Diabetes, or diabetic peripheral neuropathy, affects 60 to 70% of patients that are diagnosed with diabetes, making this the most common disease that affects the nervous system. So what is it? Well, it's defined as a progressive neurological disorder that affects the peripheral nervous system. It often presents in a stocking and glove distribution. And what I mean by that is it usually starts in the fingers and toes and works its way up the leg or the hands and arms. And it accompanies mild to severe symptoms including burning, tingling, numbness, pins and needles, pain worse at night. It can be very, very controlled to severe and excruciating, but there's a wide variety of symptoms that can occur with this disease process. So how long have we known about diabetic neuropathy? Well, the earliest studies that we found, 1798, by an English physician, Dr. Rollo, who described a patient with intermittent pain, numbness, and paresthesia. Fast forward to 1887, Dr. Price describes a painless foot ulcer in a diabetic patient, suggesting that it was the result of nerve degeneration caused by the diabetes disease process. Well, it's 2018. We, the scientific community, still don't know exactly the mechanism of diabetic neuropathy, although there's been several theories that have been published and postulated, and I subscribe to one particular theory in specific, and I'm going to talk about that a little bit later in the lecture. Sensory, autonomic, and motor neuropathy. Your peripheral nervous system, there are three types of peripheral nerves. Your sensory nerves are responsible for sensation. So the symptoms associated with sensory neuropathy are pain, temperature, touch. You can't really feel those type of sensations as well as you normally should, and this is a major risk for developing a diabetic foot ulcer. Autonomic neuropathy. Think about the things that automatically happen that you don't have to think about. When you lose sympathetic control, it results in dry, thin, cracked skin, increased blood flow to the feet, intermittent swelling. And then lastly, motor neuropathy, reduced or absent reflexes, muscle weakness or atrophy, foot deformities, hammertoes, bunions, flat feet, Charcot, are all things that can happen with motor neuropathy, and it's also a major risk for falls and instability, particularly if you can't feel your feet and you have a foot deformity. You're at a much, much higher risk for falling than individuals that don't have those problems. So diagnosing diabetic peripheral neuropathy. Well, currently there's no definitive lab value or imaging test that I can order for you that's going to determine if you've got diabetes or not. So this is mainly a clinical diagnosis. We know that patients that have elevated blood glucose levels or patients that are on insulin are at a much, much higher risk for developing this disease process. Symptoms, like we had talked about earlier, pain, tingling, numbness, burning, pain, are all associated symptoms that are very, very common with this disease process. Now, physical examination. This picture here shows what's called a Sims-Weinstein monofilament. This is an instrument I have in my office. Most every patient that comes through with diabetes I perform this on, and it elicits 10 grams of pressure, very, very light touch, and we touch the bottom of their feet to see if they can feel it. And it's amazing to some patients that, oh yeah, doc, I can feel my feet, that can't feel this test. So it's very, very specific, very, very sensitive for that. Tuning fork, vibration. We know that patients with diabetic neuropathy can't feel vibration as well as they should. They also can't tell the difference if I'm sticking them with a sharp object or a dull object. So these are all clinical examinations that we do quickly when we perform a comprehensive diabetic foot evaluation. And then lastly, diagnostics. A nerve conduction velocity or an electromyography study can help or assist with the diagnosis. So, with those being said, at least two out of the four must be abnormal for us to consider that diagnosis. So what if a patient presents with only one of those problems? Well, we have a small, minimally invasive procedure that we perform in the office under local anesthesia called an epidermal nerve fiber density biopsy test. It's a very useful diagnostic tool in our practice when a patient doesn't clearly demonstrate all signs of DPN, diabetic peripheral neuropathy, during clinical examination. So what is that? So it's an innovative in-office diagnostic test available to help diagnose diabetic peripheral neuropathy. What we do is we inject the skin approximately 11 centimeters proximal to the outside of the ankle, and we take a little skin biopsy. And what that determines, or what that tells us, is that if a patient has small fiber peripheral neuropathy, which is mostly linked to the sensory neuropathy, so the pain, the numbness, the tingling, and the burning, we can readily and accurately help diagnose these conditions. We at Louisiana Foot and Ankle, I believe, are the only foot and ankle specialists in Lake Charles that are currently performing this procedure. And we send this to a special lab based out of Atlanta that helps determine and helps with these readings. So it's a very, very unique and useful tool that we use in our practice when we have a patient that is on the borderline or on the cusp of having DPN or diabetic peripheral neuropathy. So treatment. So how do you treat it? We know that you have it now. How do you treat DPN? Well, first, metabolic control. Strict glycemic control and the regulation is the #1 most effective form of diabetic peripheral neuropathy. Your blood sugar has to be under control for you to have any maximum benefit from any other adjunct treatment that exists. Now, there are medications, non-steroidal anti-inflammatories, tricyclic antidepressants, local anesthesia, opioids. There's a variety of nutritional supplements that exist that do help and target diabetic peripheral neuropathy, and we're going to get into that a little bit more. Medication is the #1 form of treatment for diabetic peripheral neuropathy in the United States, and I think you'll be surprised by some of the findings that you see in this presentation. Next is laser therapy. Who here's heard of laser treatment in this room? We have the only FDA-cleared laser that is intended to treat musculoskeletal and neurological disorders associated with diabetic peripheral neuropathy in our office. And I'm going to talk a little bit more about that. And the theory behind it is that it stimulates increased oxygen and microcirculation around the nerve fibers. It increases blood flow to the nerves, and it helps heal and reduce neuropathic pain via the use of light energy. And then lastly, surgery. And I'm going to talk about some of the peripheral nerve decompression techniques that I use in my practice, as well as my partner, Dr. Przybylski, does as well. So, like I said, you've got to control your blood sugar for you to have success in reduction of symptoms with this disease process. Normal blood glucose levels, 115 milligrams per deciliter or less fasting, dietary control, exercising, blood glucose monitoring, insulin and oral agents, and stress reduction. I cannot tell you how many times I see a patient come to my office who's referred by their primary care doctor with diabetes that have pain, numbness, burning, and tingling, and I ask, well, how does their blood sugar run? And they have no idea. They don't own a glucometer. They don't check their blood sugar. So controlling your blood sugar is by far and away the most common thing that you have to do before we get relief with this condition. So true or false? There is an FDA-approved medication designated for the sole treatment of diabetic peripheral neuropathy. Who thinks that statement is true? Who thinks there's a drug out there that exists that is intended to treat diabetic peripheral neuropathy? How many think that's false? Good. That is false. Now, are there medications that treat DPN? Yes. However, these drugs are not designated for the sole treatment of DPN. In other words, it's an off-label use. The 3 FDA-approved medications for DPN that exist today is Cymbalta, Lyrica, and Nucynta. Cymbalta or duloxetine is an antidepressant used to treat depression. Lyrica, or pregabalin, is an anticonvulsant used to treat seizure disorders or epilepsy. Nucenta is an opioid analgesic. Now, who here has heard of this opioid crisis that we're currently in? This is a problem because these patients are in excruciating pain. It affects their activities of daily living, and yet there's not a lot of benefit or relief, and these drugs do come with side effects. So then what? You know, they oftentimes end up referring or coming to opioids for this type of problem. Laser treatment. So literature and published studies on the effectiveness of laser therapy and DPN began back in Russia and Europe in the 1960s. And like I said, we do have, this is actually an exact picture of our laser we have in our office. So how does it work? It releases chemical endorphins that reduce pain. It decreases swelling. It increases blood flow and promotes angiogenesis. And it helps stimulate the repair and regrowth of damaged nerve tissue. Now, in our practice, we utilize this quite a bit to help with diabetic nerve pain. And I tell you, you know, while there's literature and studies that do need to be improved, the effects that we're seeing with our patients is nothing short of remarkable. It really is. Here's a picture of my partner performing the laser therapy. I don't know what's going on with my facial hair in this picture, but I apologize in advance for that. But this is how we treat. You can clearly see that it's done in office. There's no anesthesia. It's very, very safe and effective. So what are the pros of laser treatment? It's safe, it's effective, it's painless, patients get immediate relief, it's affordable, and there's no side effects. What are the cons? Well, the biggest con that we encounter is that it's a non-covered service or benefit by insurance companies. A lot of people think that if it's not covered by the insurance, it's not for me. And as we continue to evolve with new technology that's intended to treat not just neuropathy, but any condition that exists in the human body, insurance companies don't always provide coverage for these treatments, but there are treatments out there that can help significantly with this condition. This does require multiple treatments to get maximum benefit, typically twice a week for 6 weeks, or a 12-session package that we encourage patients to purchase. But I tell you, our results have been very, very good. And again, more literature and studies are needed to prove the effectiveness of this condition. The more literature we have, the more studies that we have, well, who knows? I mean, maybe this does become a covered service in the future by insurance companies. The surgical treatment of diabetic neuropathy. So when all else fails, medication fails, strict glycemic control, laser therapy, then we consider potential surgery. So what happens to the peripheral nerve in patients with diabetes? So the peripheral nerve is subjected to hyperglycemia, or elevated blood glucose levels, that becomes swollen and susceptible to compression. These peripheral nerves have the less ability to repair themselves, and it slows axonal transport. Now, this here is the inside of the foot. So here's the inside of the ankle, here's the heel, here are the toes. There's a ligament that courses from the medial malleolus down to the heel bone in which that nerve passes under. The posterior tibial nerve branches into 3 different nerve branches as it passes through the bottom of the foot. The medial plantar nerve, the lateral plantar nerve, and the medial calcaneal nerve branch. The tarsal tunnel is a very well-defined constrictive area. So if you've got a nerve that's swollen, that's passing through the bottom of the foot, and you're constantly walking and weight bearing, well, this can lead to some pain. This can lead to some discomfort. And I'm a big believer in this procedure, but you got to be the right candidate for the procedure. So these are some intraoperative pictures for my patients that have undergone this procedure. Again, we're still in the same area. The toes are here. Here's the heel bone. Small incision, usually 4 or 5 sutures to close. And we just release the ligament that's compressing the nerve. We don't do anything with the nerve. Obviously, if the nerve is damaged or irritated, we can use other modalities to help with that swelling. But this isn't a majorly involved or invasive procedure by any stretch of the imagination. This is performed a lot of times under local or general anesthesia, same-day surgery. So true or false? If a patient suffers from diabetes, they should not have foot surgery. Who here has heard that? If I'm a diabetic, I shouldn't have surgery. Anybody heard that? That's false. In fact, there's more foot surgery performed on patients with diabetes than without. Remember, 1 in 11 people in this country have diabetes. Now, obviously, it's imperative to perform an appropriate preoperative test and conduct a thorough physical examination, assessing their circulations and then their glucose levels. This is a very, very important slide here. If your hemoglobin A1C is greater than 7, you have a known increased risk of postoperative infection and compromised wound healing for elective foot and ankle surgery. So that is a lab value I will always get for any patient that I'm considering performing surgery on that does have diabetes. So who are candidates for the nerve decompression surgery? Well, you have to have the presence of symptomatic neuropathy, pain, tingling, and burning. I find patients that present to my office with the chief complaint of just numbness. They just can't feel the bottoms of their feet. Oftentimes don't get as much benefit from this particular procedure. Not saying that they don't, but those that are having pain and burning and tingling are the ones that get a lot of relief from this procedure. A positive Tennelle sign over the tarsal tunnel indicating a site of nerve compression. So back to the slide. During a physical examination, if I press in some of these areas, patients will get sharp shooting pain that can shoot towards the big toe, shoot up towards the knee, or create a burning sensation. I can almost recreate the pain that they're describing. That's a positive Tennelle sign. The patient cannot have an active or open ulcer or an infection, and they have to have an A1C of less than 7.5. So here's a case study. Patient presented to me with left foot pain, burning, swelling, numbness, irritation, mainly to the left foot. Her right foot was just numb for about 1.5 years. She rated her pain scale as a +8 out of 10. She was a 55-year-old African-American female with past history of type 2 diabetes, insulin dependent, hypertension, and obesity. Her A1C was 7.2. She works as a cashier. She's on her feet 8 to 10 hours a day. No smoking, no tobacco, no illicit drug use. Her medications included an insulin-dependent diabetic drug regimen, beta blocker for her hypertension, gabapentin was prescribed by her primary care doctor. Remember, that's the only medication. Medication is the #1 treatment for DPN. She's been on gabapentin for about 3 years before I met her, and she was on a baby aspirin. So physical examination, she had a positive Tennelle sign, she had decreased sensation, and she had good circulation. We did indeed order a nerve conduction velocity test on her to confirm, and she had findings consistent with polysensory neuropathy and bilateral tarsal tunnel syndrome. Now, her left foot was the only symptomatic foot that had pain, burning, and tingling. Her right foot was completely numb. So what we did is we considered the patient for an open tarsal tunnel release of the posterior tibial nerve decompression of the left foot. So this is her in surgery. You can see our small incision that we make on the inside of the foot and ankle. This is the ligament that compresses that nerve. We release that ligament, and this is an instrument here called a forceps, or a hemostat rather, showing that now that nerve can pass unimpeded through the bottom of the foot. And this is her after the surgery. 1, 2, 3, 4. 4 stitches. Small incision. Post-operative course. Patient was placed in a protected cam walker or walking boot with crutches for 3 weeks. We removed her sutures at 2 weeks. She reported a +2 out of 10 pain at her 2-week post-op visit. Patient reported a +0 out of 10 pain at her 8-week post-operative visit, and we began tapering that patient off her gabapentin entirely. Saw this patient for a 6-month follow-up, +0 out of 10 pain, 6 months after surgery. This patient has been in pain for over 2 years, has taken gabapentin, thought about taking opioids to help with her pain, and a 25-minute procedure, we've gotten rid of this patient's pain altogether. So this is an example of a surgical nerve decompression. Now, with my time constraints, I'm not going to talk about some of the other nerve decompression surgeries I do, because this is by far and away the most common. But if we go back here, you can get a compression along the top of the anterior ankle of the deep peroneal nerve. You can also get a compression up along the lateral leg of the common peroneal nerve that we also do ligament releases for that helps with some of these symptoms. But the pain and the burning on the bottom of the foot does very, very well with this isolated nerve release. So true or false? All diabetic peripheral neuropathy involving the foot and ankle is painful. It's false, right? You can have numbness. It's false. And in fact, many patients that suffer from diabetes are insensate. They can't feel the bottom of their feet. This is very dangerous. Lack of sensation to the bottom of the foot, increased repetitive stress to the bony prominences, to the plantar bottom of the foot, leads to microtrauma, skin breakdown, callus formation, and ultimately, I'm glad you guys are done eating, a diabetic foot ulcer. This is real life. I see this every day, all day in my clinic. Every single day, I see patients that come in with holes on the bottom of their feet. This is a diabetic foot ulcer. This is an absolute epidemic. In this next slide, I want to read very, very slowly. If there's anything you take away from this presentation, it's this next slide here. Every 7 seconds, somebody dies from diabetes. Every 20 seconds, a limb is amputated due to diabetes or diabetic complications. 50% of those patients will have their other limb amputated within 2 years. 25% of diabetic patients will develop a foot ulcer. That's 1 in 4. 84% of diabetics that undergo an amputation are preceded by a foot wound, meaning that that foot wound had a complication, it got infected, and that's what caused them to undergo that amputation. 84%. Greater than 60% of diabetic patients will develop peripheral neuropathy, and 90% are unaware they even have it. Chronic ulcers affect 8 million Americans per year. That's a new ulcer developing every 3.8 seconds. Someone else just got a wound. More than 50% of patients with diabetic foot ulcer will be admitted to a hospital at some point for infection related to that complication of the wound. 25% of those patients that get admitted to the hospital for that infection will undergo an amputation during that admission. 68% of patients have a 5-year mortality rate after a leg amputation, meaning a gentleman of mine that went for an amputation Monday has a 68% chance of not seeing 2023. 68% chance. That is the second highest mortality or 5-year mortality, second only to lung cancer. Colorectal cancer has a 39% 5-year mortality. A leg amputation associated with diabetes, double that. Breast cancer has a 23% 5-year mortality. A diabetic limb amputation, triple that of breast cancer. So if you asked me today if I would rather have diabetes or cancer, what do you think I'd say? Exactly. The staggering cost of diabetes. This is also a good slide. I took this directly from the ADA. They put it in terms better than I could. Diabetes affects 30 million children and adults in the U.S. That's 1 in 11. 84 million people in this country are pre-diabetic and have no idea. Every 21 seconds, someone in the U.S. is diagnosed with diabetes. People with diabetes are at a higher risk of complications, including stroke, blindness, kidney disease, heart disease, loss of toes, feet, or legs. The economic cost. Diabetes costs the health system $322 billion a year. A year. Insulin has increased in price by 3 times since 2002. So the direct cost of diabetes to our healthcare system. In 2012, $245 billion, direct cost. It was $174 billion in 2007. 41% increase in 5 years. The 2017 numbers have not been released yet, but I can bet you they're going to be well over $300 billion of direct cost, not indirect cost. Indirect cost of our health system, $69 billion a year. So if a patient has a wound on the bottom of their foot that I'm treating, that dressing is going to have to be changed once, twice, maybe even 3 times a day. If they don't have the flexibility to get down and change their dressing themselves, we send a home health care nurse out to do the dressings for them. In order to qualify for home health, you have to be homebound 85% of the time or more. And oh, by the way, if you have a wound on the bottom of your foot, you can't put pressure on that. You can't walk. So how can these patients be gainfully employed? It's impossible. They cannot. So $69 billion a year are due to lost wages, disability, or early mortality. So what happens when the prevalence of diabetes in this country affects 1 in 3 of us in 2050? What's going to happen to our healthcare system? What's going to happen to our insurance plans? So who pays for this now? The cost of care of diabetes, 62.4% are paid by government-funded insurance plans. That's Medicare, that's Medicaid, and that's military insurance. TRICARE in this state in particular. 30.4% are privately insured, and 3.2% by self-pay. Did you know of this problem? So what about the people that don't have health insurance? Who here in this room knows somebody without health insurance? Does anybody know? There are 11.2% of Americans currently live without health insurance. Those that are diabetic without health insurance have 79% fewer office visits than those that do. Those that are diabetic are prescribed 68% fewer medications than those that do. The ones that don't have insurance yet have 55% more visits to the emergency department, further increasing the cost of care. So the cost of a DFU, location matters, whether it's inpatient at the hospital or outpatient in my office or at the wound care center where I treat patients. Complications associated with diabetic foot ulcers, infection, hospital admissions and readmissions, ancillary services, revascularization procedures from cardiologists, surgery procedures, wound devices, skin graft substitutes, hyperbaric oxygen therapy, all things that are necessary to heal diabetic wounds in more cases than not. So, this is real. This is what I see on a regular basis at this hospital for consultations. Complications from a diabetic foot wound is the #1 reason diabetics are admitted to the hospital, whether it's for infection, a non-healing wound, or even gangrene. 25% of diabetic foot ulcer patients admitted to the hospital with one of the above stated complications will undergo a surgical procedure during that stay, whether it's a debridement by cleaning up some of this dead non-viable tissue, or whether it's an amputation, or whether it's a cardiology intervention to improve circulation to the foot so that wound can heal. The cost, the average cost of a hospital admission in which a patient undergoes surgery is between $30,000 and $60,000 to the to the insurance company. And tack on another $45,000 to $60,000 for the 3-year aftercare. This is a problem. You know, it's certainly a problem. So, diabetic neuropathy in diabetic foot ulcers. How do they correlate? 90% of patients with a diabetic foot wound have diabetic neuropathy. 90%, that's 9 in 10. It's a virtual certainty when a patient walks in my office that has a wound on the bottom of their foot, they can't feel it. Diabetic neuropathy can mask the severe complications associated with peripheral arterial disease, pain, infection. This is gangrene. That tissue is dead. So what is PAD? So peripheral arterial disease and diabetic neuropathy. PAD, peripheral arterial disease, and DPN are the 2 leading causes of non-injury related amputation disabilities in the United States. So what is PAD? It's a common circulatory problem in which narrow blood vessels reduce blood flow to your limbs and feet. Signs of peripheral arterial disease: intermittent painful claudication. Claudication is Latin for limp. You'll have patients that can walk a block or 2 blocks and then get excruciating cramping to their calves. And why that is that their muscles are becoming hypoxic because they don't have blood flow or circulation to that area. Patients then can develop rest pain, cold and numbness, hair loss. Non-healing wounds and ulcers are all signs of peripheral arterial disease. So what you're saying is that if I have predictable leg pain or cramping with activity, I should go see my podiatrist or primary care doctor or cardiologist. That sounds simple enough. Well, yes, you should do all these things, but it's not that simple. Let's harken back to neuropathy and numbness, the inability to feel. What if I told you this patient presented with absolutely no pain at all? That did not bother this patient one bit. This patient's wife saw his foot looking like this. This guy had no idea that his foot was in this condition. Diabetic neuropathy can mask painful warning signs, like the intermittent claudication, that are associated with peripheral vascular disease, which is why it is such a tough thing. When you see a diabetic ulcer, you have no idea if the patient has good blood flow or not. So before proceeding with any surgical debridement, obviously this tissue is not good, that has to be removed. We have to do a thorough workup of the peripheral vascular disease to understand and see if this patient's going to heal these wounds. So the most common locations for a diabetic foot ulcer. Number one, the fat pad of the foot. By far and away, this is where we will see the majority of foot ulcers. Number two, you'll see on the top or the distal tuft of the toes. And then lastly, number three will be the heel or the midfoot. But by far and away, the most common place we see these develop are right here at the fat pad of the foot. So peripheral neuropathy and sensory neuropathy. So we already talked about sensory neuropathy, not being able to feel your feet. Well, let's also talk about motor neuropathy. Motor neuropathy can lead to what? Deformity of the foot, hammertoes, bunions, changes the shape of the foot. So a patient is walking on something they can't feel with abnormal bony prominences that they can't feel. That's going to lead to a much, much higher risk of developing these said ulcerations. So the most common question I get from my wound patients is, so when is this going to heal? And I tell them, I have no idea. But what I can tell you is this: 4 weeks. 4 weeks is predictable for wound healing. If a patient comes to me day one with a new wound and we take a measurement of that wound, we've got 4 weeks to get that wound 50% or smaller. If that happens, there is a 56% chance of healing that wound in 3 months. Think about work. Think about time off work. In Louisiana, hey, we're blue collar. We work. There's not a lot of patients that can afford to take time off work that support their family, that have bills to pay. So unfortunately, the majority of my patients fall into this category here. The wounds don't improve or decrease in size by 50% or more in 4 weeks. There's only a 9% chance this thing heals at 3 months. 9% chance of wound healing at 3 months. So every time a patient asks me, when is this wound going to heal? I have no idea, but we will know in the next 4 weeks. What factors affect diabetic foot ulcer healing? Age is the big one. Comorbidities, heart disease, obesity, cancer, immunological disorders. Medications such as immunosuppressants and corticosteroids make it much, much harder for the body to elicit an immune response for healing. Nutritional support. If your blood sugar is highly elevated, your body can elicit an immune response to try healing these wounds. Smoking. Now, I'm not going to pick on anybody in this room because you guys came out to see me, but who here knows somebody that smokes? Almost everybody, right? Smoking delays wound healing substantially. Vascular status, we talked about that earlier, PAD. Pressure, walking and weight bearing, very, very important for my diabetic foot ulcers. And then wound environment. So, we've been treating this wound now for greater than 4 weeks, and we haven't seen much of an improvement. Now what? Well, now is when we delve into some of the more advanced techniques that we can use for wound healing, such as advanced imaging. Let's make sure the patient doesn't have an infection that we just can't see on plain x-ray. Tissue culture and biopsy, and I'm going to talk about the overprescribing of antibiotics in wound care. Advanced offloading techniques, hyperbaric oxygen therapy, skin graft substitutes, and lastly, surgery. So, if a patient comes to me with a foot ulcer that's not healing, the x-ray is negative, am I missing something? I'll order an MRI. An MRI is much, much more sensitive and specific for soft tissue and bone infection. Or a bone scan. A bone scan is a sensitive and specific test to rule out infection when an MRI is contraindicated. I find an MRI is far superior in diagnosing soft tissue and bone infections than a bone scan is currently. That's more of an older technology, but it still has its indications today. But yeah, an MRI is much, much superior in my hands or in my estimation than a bone scan will ever be. CT angiogram, sensitive and specific diagnosing and visualizing the peripheral arterial system. Does the patient have enough blood flow to heal the wound? And these are all adjuncts that we can order to determine why this wound simply isn't healing. Tissue culture. You may have seen a tissue swab or a tissue curette or biopsy. There's quantitative bacteriological culture to molecular diagnostics with DNA sequencing and PCR analysis. I mean, this is high-tech stuff that we're ordering on these patients to figure out why this thing isn't healing. I'm a big believer in know what you're treating. And there's so many times patients come to the ER or the urgent care, they have an infection. What do they get diagnosed or what do they get prescribed? Antibiotics. We have no idea what bacteria is causing that infection. So what's happening is that there is a lot of bacteria that are becoming drug resistant, meaning that the penicillins that we were normally prescribing aren't touching some of these bacteria that are causing these problems. So know what you're treating before you treat it. Sometimes we're not in a position to do that, and I get that. But if we have a wound that is starting to show signs of infection, I'm going to take a culture before I prescribe them something, because a lot of times the patient will either what? They'll start taking the antibiotic, and it'll start to improve, and then they what? They stop taking it. Their body can then develop a resistance to that antibiotic. So even though the bacteria that they're growing out is sensitive to said antibiotic, their body has already developed a resistance to it. So it is very, very important to know and understand what you're treating. Offloading. So here are some sample techniques of things that we do to help offload these wounds. Cam walker, custom healing sandal, foot casting, and total contact casting. So any patient of mine knows that I fuss. I fuss at my patients when I see them coming in. We've spent hundreds of dollars getting them this nice brace or this offloading boot, and they come in sandals or tennis shoes. My staff sees it all the time. Offloading is so important because persistent pressure to a wound can alter the capillary network that is in the base of that wound. If the capillary network is altered, decreased blood flow is going to that wound, and therefore the wound's not going to heal. If you look at some of the literature out there, we talk a lot about total contact casting. Now this boot here weighs about 6 to 7 pounds. So if you're in your 60s, 70s, and 80s, and you've got to lug around this 7-pound boot that, oh, by the way, you can't get wet, you can't take it off, that's a problem for a lot of people. Oh, and by the way, you can't have a wound that's draining that needs daily dressing changes. You can't have an infection, and you can't have poor circulation, which is a large patient section of our patients. So while yes, total contact casting is the gold standard of offloading wounds, it does decrease healing sizes. There's a whole heck of a lot of wounds that just don't qualify for this. So patients have to understand the importance, and that is something that I do spend a lot of time with my patients just explaining, because the wound doesn't hurt to walk on. Why can't they walk on it? They got to get around somehow. What else are they going to do? Hyperbaric oxygen therapy. Now we have chambers here at Lake Charles Memorial Wound Care Center. I do refer quite a bit of patients over that way for HBO therapy. Hyperbarics involves exposing the body to 100% oxygen at high pressure. Wounds need oxygen to heal, and exposing wounds to 100% oxygen can in many cases speed up the healing process. So this is an example of a hyperbaric oxygen chamber. Who here in this room has heard of hyperbarics? Right. So this gentleman here, watching TV, taking a nap, it's very, very comfortable. What is the problem with hyperbarics? Well, hyperbarics is a Monday through Friday treatment Lasts anywhere from 90 to 120 minutes. And the treatment length is about 30 to 40 treatments. So you're looking at a minimum of 6 weeks, Monday through Friday. Give me 3.5 or 4 hours of your time. In other words, what? No working. Possible side effects of the treatment: pressure-related ear nasal trauma, possible oxygen toxicity, and decompression sickness. I find that this form of treatment is very, very helpful when I'm treating bone infection, or I'm treating patients that have small vessel blood disease or small vessel vascular disease. There's big vessels, macrovascular system, and there's small vessels, the microvascular system. When we start dealing with blood vessels that are small in our fingers and toes, you can't get a stent or a balloon down there to open that up. There's no cure for microvascular disease except medication. Well, hyperbaric oxygen therapy has proved to be a very, very good adjunct for some of these difficult healing wounds, but it is a time commitment, no question.
Is that good for surgery? Like, I know my daughter's sells veterinary and pharmaceutical things, and I went to a clinic, and they have a big old vat of horses that they walk in.
Yeah, oh, it's wonderful. It's used for a lot of different treatments other than just diabetic foot ulcers, no question about it. No question about it. I trained in Miami, where we had a lot of divers that came up too soon, called the bends. Hyperbarics is a perfect treatment option for that.
Yeah, I wish I was sure for that decompression.
Exactly. So, skin graft substitutes. Now this is very near and dear to my heart. And you're going to see some very, very good case studies here that show the effectiveness of skin graft substitutes. So allograft, human cadaver skin and amniotic membrane. Amniotic membrane and human cadaver skin have a high volume of living cells that help accelerate wound healing. Amniotic membrane therapy is rich in cytokines, rich in growth factors, it speeds up healing, and it lacks immunogenetic properties, which basically means that the body can't reject it. It has been a wonderful adjunct to our practice, and this is something that is very, very exciting and on the forefront of wound care. Xenografts, bovine and porcine. Now before you guys go and tell your friends that Dr. Hall puts pig skin on patients, understand that from a histological perspective, pigs and cows and humans share very, very similar effects. In fact, some of you guys in this room might have a heart valve that's from a pig. This is a very, very common thing we use. And again, xenografts are very, very affordable, and they're very, very effective with healing wounds. Lastly, synthetic and biocomposites. Collagen, polymers, silicones, all things that I use for my larger cases when I'm trying to get coverage of bone or tendon or structures that are super at risk for developing an infection. Case study. So this patient is an 81-year-old African-American male, type 2 diabetic, obesity, hypertension, and peripheral vascular disease that was admitted to the hospital for a non-healing right foot wound. Patient underwent a right lower extremity angioplasty here in the hospital with a cardiologist due to moderate blockage of his right lower extremity. Who here knows what an angioplasty is? Has anybody ever heard that term? An angioplasty basically is a procedure done by a cardiologist specialist that goes into the blood vessels and opens them up to increase circulation to the foot. That's an angioplasty. This is something that is very, very commonly done. I work very closely with the cardiologists here at this hospital and other hospitals in the area that know that this is what I do. And I know that there's no way I'm going to be able to heal a wound if I don't have blood flow to get there. So this is a common thing that we get before we start doing our invasive procedures. So I was consulted to evaluate and recommend treatment for this right foot wound. Now this patient went multiple debridements inpatient while at the hospital, took him back to the OR for multiple washouts and irrigations and debridements. And we treated this guy for about 16 weeks. And I would put greater than 8 weeks, but it was about 16 weeks. But we just couldn't get this dang thing closed. It was a healthy wound, it was viable. I went back and said, hey, does the patient have infection? The cultures were negative. MRI was negative for osteomyelitis. Rechecked the stent to make sure it was still open. No blood flow compromise. Why isn't this thing healing? So what we decided is we decided to initiate an advanced skin graft substitute to complete this wound closure. Now, allografts are not from the individual person. That is what we consider an autograft. And with this high-risk patient population, I don't find it all that beneficial to take wound or take skin from the thigh or leg and slap it on the wound that's not healing. Now I've got two wounds with a 10 to 15% chance of graft failure. So we use allografts. This is not tissue from the person itself. This is a donated tissue form. So this is a picture of the wound. 16 weeks, we cannot get there. You can see how big that ulcer was. But we finally got down to this, and we spent 6, 7, 8 weeks at this same tissue level. This wound measured 4.6 by 2.5. We put the graft on him, as you can see here in this picture, and we secured it. Patient doesn't touch it for a week. This is what the wound looked like 2 weeks later, after that graft. Now measuring 3 centimeters by 1 centimeter. Well, this is working. We're going to put another graft on him. This is what the wound looks like 2 weeks after the second graft. Measuring 2 by 1, 50% reduction in size. 3 weeks after the third graft application, the patient closed up. 7 weeks after the graft application, the patient is still closed. Case study number 3. This is a 44-year-old white gentleman, past medical history of diabetes. He does have a history of a midfoot amputation, as it turns out, due to a complication from what? From a diabetic foot wound. We employed strict glucose control. He was controlling his blood sugar. We were offloading the wound. Did not see a decrease in size in 4 weeks. Wound cultures were negative. MRI was negative for infection. Blood flow studies show good distal perfusion. We decided to initiate advanced skin therapy to help this gentleman. So this is the initial wound, measuring 3 centimeters by 2 centimeters. 2 weeks after the graft application, 1.7 by 0.9 centimeters. 2 weeks after, 0.7 by 0.3. 1 week after that third graft application, we healed the wound. 6 weeks after, the patient remained closed. So, what if we employ these things? If I do these tissue grafts, if we check for infection, if we make sure there's no blood flow issues, and the patient still has problems, well then when is surgery indicated? And I find that, and again, I've condensed this presentation. I do a plethora of procedures for diabetic foot ulcers, but these two are the most common procedures that I performed 2 or 3 times a week on our patients. The Achilles tendon contracture and digital deformities. Now, it's important to understand that diabetics and their tendons and ligaments become awfully stiff after a while. And this is caused by non-enzymatic glycation. Say that fast 5 times. Non-enzymatic glycation basically means that the tendons become very, very stiff and the patients don't have range of motion. So think about this foot for a second and think about the heel and how the Achilles tendon inserts here. We know that the Achilles tendon causes the foot to go down. So if the tight Achilles tendon is present, that foot can't go up very high, leading to an increased pressure point here. And with neuropathy and other things, patients can develop a diabetic foot ulcer there. Digital deformities, same as we had discussed in the previous slides with the motor neuropathy, can develop hammertoe deformity, so they can get rubbing from their shoes or they can get ulcers at the tips of those toes. So what do we do for the Achilles tendon contracture? Well, we lengthen the Achilles tendon. Now this is done either in the office or at the hospital, usually done outpatient surgery with a little anesthesia. And I make 3 little stab incisions to the back of that Achilles tendon. Now this particular patient here had bilateral fat pad ulcerations, and he elected to do both at the same time. This does require non-weight bearing post-operatively, roughly 3 weeks in a cast or in a wheelchair or on crutches or other multiple offloading devices that exist today. That is very, very important. If a patient was to walk on this after we perform this procedure, they're at a high risk of developing a tendon rupture or over-lengthening that tendon. But this is something that works effectively. This patient in particular here, he was immobilized for 4 weeks, and both wounds were healed by the time we took the cast off. So very, very effective, and the patient comes in every 4 months for a checkup, and he has not developed so much as a callus to that forefoot since we did that lengthening procedure. Hammertoe surgery. Now this slide is a lot harder to see than when I did this presentation, but there is a small minimally invasive technique we employ in our office called a flexor tenotomy. This is strictly an office-based procedure, same day. We give a little local anesthesia to numb the toe, and what we do is we come in through the bottom of the toe here and we release this structure called the flexor tendon. That flexor tendon is responsible for making that toe curl. So by releasing that tendon, that toe pops back straight. So you can see here, whenever you're standing or sitting in an exam chair when I come in, if you don't have a digital deformity or hammertoe, your toenails should be facing the ceiling. This patient had wounds on both second toes. So this patient's 2 weeks post-op of us doing that little procedure, and you can see the position of her toe compared to that. This healed up, this did not. We did this procedure on this foot the same day of this picture. So who qualifies for this? Well, if you have an ulcer on the distal tuft of the toe, or if you have an ulcer on the top of the toe, and this is somewhat flexible, you're an excellent candidate for the procedure. We don't use a tourniquet. This is a 5-minute procedure start to finish. And it works very, very well, very, very well. Now, some of our patients aren't so fortunate. Some patients have rigid contractures. And if this is the case, this does require an open technique in which we remove a little portion of the bone. Sometimes we fuse the bones in the toe to hold them perfectly straight. But again, this can be done in my office. This can be done outpatient, usually under local anesthesia. And you can see here this patient underwent hammertoe correction of digits 2, 3, 4, and 5. And this is the post-operative outcome. Straight toes. The patient has never had an ulcer since then. And she's doing very, very well. So these are little minimal surgery techniques that we can perform. I know when patients hear surgery, they think, oh my God, it's this big, stressful thing that I have to undergo. But I assure you, there are so many different techniques that we can employ, particularly minimally invasively, in which you'll never know that you had the procedure, and a lot of it can be done in the office without anesthesia at all. You don't have to stop your blood thinners. It requires no anesthesia. It's very, very effective. So in summary, diabetes is a very intricate disease process that affects 1 in 11 people in the United States. Diabetes is a treatable disease, and with strict glycemic control, many of the potential complications can be avoided altogether. Greater than 70% of our diabetic patients will at some point develop peripheral neuropathy. Greater than 90% of patients rather, that have a diabetic foot ulcer have neuropathy. Regular podiatric medical care and evaluation in patients with diabetes can decrease amputation rates by 74%. Early intervention is crucial in slowing, if not reversing, the symptoms of peripheral neuropathy. Blood glucose control and monitoring is essential for wound healing and controlling neuropathic symptoms. If a DFU or diabetic foot ulcer does not improve in 4 weeks, the chances of healing at 3 months is only 9%. Seek a qualified foot and ankle specialist or podiatrist or wound care specialist immediately if you develop a wound or an ulcer and you suffer from diabetes. And if you suffer from diabetes, it's important to check and monitor your feet regularly. That's it for me, guys. Are there any questions about things that we discussed?